All right. Hello, everyone. Welcome to another virtual shadowing session here at Hearts for Health. Today, we're honored to be joined by Dr. Sloan. To give her a quick introduction, Dr. Sloan is an orthopedic surgeon who has expanded her roles past just the normal white coat duties. She serves as a member of several board of trustees. She's been listed on the top 25 women in Houston list and is a speaker for Comp Health and Dairy Max, national partners to the NFL and Fuel Up to Play 60 initiatives. So definitely expanded and shown her abilities as a physician leader. We're so happy to have you on board here. Really just to not only talk about orthopedic surgery, but introduce really what it's like to be a great physician leader at the front of that frontier there. So we'll get a lot of insights, and orthopedic surgery is a specialty we've covered, I think, with hand surgery before, but a lot of people were interested, and I'm glad to have that as another time or a second time. We'll be going through it for another session. For a few reminders for those who are listening in, if you're not familiar with virtual shadowing, we have speakers join us in with different specialties, different speakers each time. We'll be going through a Q&A at the end, usually towards the last 10 to 20 minutes. And with that Q&A, you can type in any questions you have in the chat. So we'll answer those questions during that time. So if you have any questions throughout this session, just type them in the chat. And once that Q&A rolls around, we'll cover them. To stay updated with future virtual shadowing sessions, you can follow us on Instagram and also join our listserv. To join our listserv, either email us at shadowing.h4h@gmail.com with your name and email, and we'll add you on, or you can subscribe at the bottom of our web pages where we have a subscription form. Either way works, but that's how you can get added on, and we have weekly announcements over new sessions through our listserv, along with a few resources. But with that covered, Dr. Sloan, feel free to take it away.
All right, so I'm going to share my screen and make sure you guys can see this. All right. So hi, I'm Dr. Sonia Sloan. I am an orthopedic surgeon, and a lot of people don't necessarily know what that is, or they get it confused with what that entails. So today we're going to sort of talk about what it is, what it takes to be an orthopedic surgeon, what we make, and maybe just the day in the life of what shadowing would look like if you did hang out with me in real life. All right. So a lot of times you want to have a great passion. So you guys are going into medicine, or you're thinking about going into medicine, and what really is going to make you successful is your why. And so for me, this is an MRI actually of my knee. That was when I was a hurdler. I was running track, the 100-meter hurdles, hit my knee that was coming across on the last hurdle and subluxed my kneecap, which basically means it moved to the side. And so that's not considered a dislocation of the knee. That's actually just a subluxation of the knee, of the patella. But what you can see is all this white is bad. This is the kneecap itself is sitting over to the side. And what you can tell is that this is actually bruising in the femur, or the distal part of the thigh bone, where the kneecap sort of smacked it before it came back over. So needless to say, I was in a lot of pain, and my mom is a nurse of over 45 years. And working in a hospital, I got to go in and hang out, with different doctors sometimes. But what was interesting was that I never saw a female doctor. I never saw a Black doctor. I definitely never saw a Black female doctor, nor a surgeon. So for me, the thought or the concept of being a doctor was not a novel concept. I wanted to be a doctor. I just didn't know what kind. And so in spending a lot of time with an orthopedic surgeon and physical therapy and that kind of stuff, he was really very admirable in saying, you should go into orthopedics. This is a great field. It's blossoming for women. And so with that, I started investigating what was orthopedics. And so by definition, orthopedic surgery is really anything that has to do with muscles and bones, joints, specifically spine, and any joint in your hand. And remember, a joint is where two bones meet. And so that would be, between your hand and your wrist, the ends of your finger, anything that's going to bend, shoulders, elbows, knees, that's where your joints are. And so we deal with those. And then any trauma to the bones. Most of the things I do now are traumatic injuries, so fractures, dislocations. And then musculoskeletal, things that are cuts, lacerations, things that need to be sewn up. any of those things, and dealing with tendons and that stuff. So this was specifically a kid that I dealt with during my residency here at Houston at Shriners Hospital, which is a phenomenal facility. This is a little boy that was actually from Mexico, and they crossed at the border, and he had a genetic dysfunction that was a disorder that was with he and his brother. They both had it, that basically caused the neck to be somewhat unstable. So we actually went in and surgically opened up his neck and fused it to make it one piece from the base of the skull, what we call the C1 down to like C3. And they lived in the hospital for like the next 3 months while this device was on and he healed. But it was a phenomenal experience, and to see how it transformed people's lives. And they got better and they left. And so I love the fact that orthopedic surgery is something that you can fix and they walk away and you're done, you know. And there's very few times that we have chronicity with orthopedic surgery. There are certain things like myelodysplasia or cerebral palsy and some other things that you deal with, but even some of those things in the long term, you fix all those things and the patient does continue and live. But that's why I loved orthopedics, and that was my passion. And so that's something you have to think about. Why do you want to do this, and why would you want to go into this? Okay, so the question is, how many orthopedic surgeons? There's actually approximately 30,000 practicing orthopedic surgeons in the country. Of that, 94% are male, 6% are women. So the numbers for women going into orthopedics are just now starting to peak and starting to go up, but you see there's lots of room for more women at orthopedic surgeons. For the number of African Americans, we call ourselves the 1.5%. So that's men and women, Black men and women, and Hispanics are approximately a little bit less than that. For Black women to be in orthopedic surgeries, there's less than 100 of us in the country. And so that gives us a 0.6, 0.7% of the total practicing. So needless to say, you don't see many of us. And then when I do, we have most of the men are like, I want to take a picture with you or whatever else, because you just don't see many of us. And it's not the norm to have a woman practicing and doing some of the things we do. And we'll talk about some of these other procedures. This was actually a hip replacement. This was actually, I believe, a femur that we were putting a plate on down here. And so this will be a day in surgery with me. So let's talk about how many years does it take to become an orthopedic surgeon. And so I don't want to scare anyone, but I want you to do the math and understand what you're investing in when it comes to medicine, and definitely into any type of surgical field. And orthopedics is no different. So you have to go through 4 years of, let's see, this is a little delayed here, 4 years of college and get a degree. That can be a Bachelor of Science, a Bachelor's of Art. If you want to do your master's or whatever else before you go into medical school, that is something you do. I went to Texas Tech University, and I'll tell you that my college was larger than my hometown. Denison, Texas, where I was raised, was 23,000 people. I got to Texas Tech and it was 25,000 people. So it was, you get smaller in your colleges. So being in a chemistry major, it was less and less people. And as you go up into your second, third, fourth year, into your higher major, specificity, it became less. So by the time I finished my 4th year and I was doing PChem 1 and 2 or Cal 3, there was like usually 10 people in the class. So don't be afraid to go into certain fields because you think it's going to be overwhelming, or different universities, but go someplace that you definitely can have a little bit closer niche so that you can really learn this. And so after the 4 years of Texas Tech, then I went to UTMB in Galveston here in Texas. And so you got 4 years of college, and then we do 4 years of medical school, right? So 4 and 4, we're up to 8 years now. So the 4 years of medical school for you guys is intense. I'm not going to lie. Your first 2 years are pretty much books, and you're thrown such a large volume of information. You have to have great study skills and great aptitude for sitting and taking in volume and how to process that volume of information in a very short amount of time. And so this is not high school. This is not college. Medical school is a whole new monster. And so just know that going into it, that you may be the A student. You may have been the top of your class. Most of us are, but when you get to this level, you have to know who you are, your study habits, how you can optimize your time, your skills, and then also how do you adapt to that kind of volume of information that is going to depend on someone's life in the future, right? So after your 4 years of medical school, you are doctor. They will call you Dr. Smith, Dr. Joe, Dr. Sloan. And so because that means after that 4 years, you graduate with a doctorate in medicine, a doctorate in medicine degree. My degree is back here on the wall behind me. And so that degree is very, very important, and no one can take that away from you. So now you get the long white coat, where we say the short white coat is like where you're pre-med and in medical school. And then once you finish, you get the long white coat, which is you've graduated to the next level, right? Then you go into your residency. So we got 4 years of college, got 4 years of medical school. Now let's look into residency. To be a surgeon, you have to do a general year, 1 year of general surgery. I don't care what you go into. That means neurosurgery, plastics, ENT, cardiothoracic, ortho, urology, all of those things. You're going to have a year of general surgery. And the concept is that no matter what field you go into surgically, you should be able to manage a surgical patient, and that deals with basic general surgery principles. So you have that first year is going to be your general surgery year. I chose to do a year of research when I was working at NASA, and I did some work on shoulders and got the articles published. So that year of research helped me become a published author. And then I still had to do 4 years of orthopedic surgery. So 4 years of undergrad, 4 years of medical school, a year of general surgery, a year of research, and then 4 more years of orthopedic surgery. So for me to complete and be done, it's been 14 years to get to where I am as an orthopedic surgeon. And then there's still people that will go on to specialize. Like I believe Michael was saying earlier, you guys have had a hand specialist. That's another year fellowship, sometimes 2 if they do plastics as well. And then we can talk about some of the subspecialties later on. All right. So let's go to the operating room. What does that look like? What does a day in the OR with the orthopedic surgeon look like? You definitely need an assistant. Most of the time, the things that we do, you need someone to be able to hand the equipment off to you. And yeah, we deal with power tools. I mean, this is a drill that you're looking at here. This is considered a reamer that has like a drill bit on the end of it that we drill bones and drill holes. This patient here is someone we were doing, I believe, a femur on. And so the implants that go in, we have to start with an awl. Some of these things that you see on the field over here is a rake. Anything you can find in a hardware store, orthopedics probably has some of the same things, right? So the rake holds the skin apart, that kind of stuff. This is a mallet or a hammer. Those are the things. So it is very not for the faint at heart, let's put it that way. Sometimes it can be gruesome. Sometimes it's very delicate work. Hand surgery is delicate work. Any of the work done on children usually is pretty delicate work. Some of the larger things and the fractures we have to deal with, though, is not always so delicate. But here's the thing. Most people, once we fix it, it heals in 6 weeks or so, and they're walking again, or they're using that arm or that shoulder or that, whatever. So it's a great field to go into, right? All right, let's see here. It's just slow to advance. All right, so what are the different types of subspecialties in orthopedic surgery? You guys have already seen someone that does with hand. Hand can be everything from a carpal tunnel to trigger finger release to someone losing a finger in amputation. We have multiple saw injuries and that kind of stuff, and you have to either reimplant and or do tendon repairs. You have people that are had bad burns or whatever else, and there's skin grafting and some other things. So hand is a very, very detailed subspecialty in orthopedic surgery. Some of the things you guys probably know if you have grandparents are hip and knee replacements, joint replacements, that kind of stuff is one of the big fields that is growing day by day because we have a boomer population that is starting to really need these implants. And so that is a very big field to go into. Shoulder and elbow usually lends more towards the either trauma or sports, which, baseball players with labral tears, rotator cuff tears. It could be trauma with AC separations or that kind of stuff. And then even just proximal humerus fractures, which I'll show you guys shortly. Trauma is one of the best fields, I think, because you pretty much take care of anything and everything, but it's done in an acute fashion. So you're going to be at a level one, probably an academic institution, doing these types of surgeries, sometimes in the middle of the night, because that's when trauma comes in, right? But this also includes a pelvic fracture, acetabular fracture, so anything around the pelvic ring. It would be stabilizing the spine if someone has what we call a fracture dislocation, and they may be almost paralyzed, and you have to almost reduce that fracture, that spine, and then stabilize them in surgery and fix it later on. So ortho trauma is sort of the general, but on the emergency room side. All right. Sports medicine, everyone loves sports medicine. That's what got me into orthopedics, knee arthroscopy, shoulder scopes. Some people will do even ankles and elbow scopes and that kind of thing. It could be ACL repairs, ligament repairs in and around joints that are specifically pertaining to athletes, right? Spine surgery, I think it speaks for itself. That can be everything from arthritis to skeletal deformities like the child that you saw at the very beginning. So spine is pretty huge, and that even includes things like tumor in the spine as well. And then pediatric ortho is a very precise field that people go into, because you're not just dealing with broken bones, you're dealing with maturing broken bones. You're dealing with genetic or metabolic things that are dealing with bones with kids. So it's not treated as the same as an adult. So definitely specialized. And then foot and ankle, where some people get confused. Oh, you're a podiatrist. No, orthopedic surgeon is not a podiatrist. Orthopedic surgeon does deal with foot and ankle. Podiatrists can deal with feet and ankle as well, usually less major trauma and fractures and anything above the ankle joint. Usually some maybe can do distal tibia, but they usually don't do anything else above that level. And then tumor, anything that's cancer related, and with the muscle or the bone, that is a subspecialty that you have to have extra training, sometimes not just 1 year, maybe even 2, right? So let's get to the nitty gritty. What everybody's wondering is like, well, how much do they actually make? So the average orthopedic surgeon in the country is about $400,000. That's the median, right? So East Coast, West Coast, of course, accommodations for lifestyles and the inflation rate and all this other stuff, it may be higher or lower. If someone is working like full-time, nonstop, that is pretty much in the hospital all the time, and or maybe in a subspecialty like total joints or whatever else, they may be making closer to the $650,000 mark, right? But even like a person like myself, I'm a traveling orthopedic surgeon. I do locums. Right now, I only want to work 7 to 10 days out of the month, and so that lends me towards the 25% mark. But still, great money if you look at it. But again, remember those 14 years that it took to get to this point. All right. So what else do I do? You guys say, oh, it's all about surgery. It's all about surgery. No, if you're going to shadow me and we're walking through this, there's a lot more than just cutting on people and using power saws to put them back together, power tools to put them back together. Orthopedics includes a gamut of, let's see here, just going to advance. X-rays, looking at X-rays, dealing with difficult patients. This little boy, his mom let me put this picture in. The cast that he had on, I think that was like number 6, the cast, not because he didn't know how to take care of the cast. It's like, it was what he was putting into the cast. So we had rocks, he had money, he had pencils, or whatever. And so you have to deal with, I call them difficult patients as well. And then you also have to have a great bedside manner. I mean, patients want to know they're putting their life into your hands and they're trusting you to take care of them when they're at their most vulnerable. They're hurt or they're being put to sleep and, they have no control. And so they're trusting you. And so those are the relationships that you build with a patient, that you can pray with them or you can hold their hand as they're going to sleep and ensuring them of all the information before surgery and even after surgery of this relationship, because now you're probably going to be closer to any of those patients than anybody else because you've actually cut on someone, that kind of thing. So it does create a different type of bond or relationship that you have to be mindful of, definitely. So how long does most orthopedic surgery cases last? Now, a basic trigger finger or carpal tunnel may be, 10, 15 minutes. It may take longer to put the numbing medicine in or put the patient to sleep than it actually does to do the procedure. And then there's some that take a long, long time. Pelvic fractures can be a 4 to 6 hour surgery. This patient, it was actually a hip fracture. This is a bad intertroch fracture is what we call this. So this is the femoral head. This is the thigh bone or the femur. And this is 1, 2, 3, 4 pieces, a 4-part intertroch. We have to put them on the fracture table. We put them in traction. And then through the skin, we make a cut and we put a rod down the inside that will go down almost like a pencil, if you will, inside of the bone, and we'll lock it with screws. Usually somewhat minimally invasive, but again, there's still, can be somewhat gruesome. And this is a different angle of that, a different patient, I believe, same procedure. The other thing that I do a lot is, we do cast, we do splints. I go to the emergency room and have to reduce shoulders. You have to go see consults in the hospital that may be a person that has a septic knee, which means the knee joint is infected and they need to go to surgery, or they need an injection in their shoulder because it's hurting really bad or whatever. So there's a lot of different things we do on top of operating. Even in clinic or in the ER, there's devices that we put in to stabilize patients. This is someone's foot that was actually dislocated, and the only way we could get it sort of stabilized before the patient could go to surgery was we put this external fixator, which is a device that goes on the outside of the leg. And so having to take these pins out later on, usually doesn't necessarily always say that we have to go to surgery to do that. So these are other things that you do that people don't even think about that orthopedic surgeons do that are still somewhat procedures, if you will. And then, of course, the basic reading x-rays and trying to figure out, okay, is this bad? Is this actually something that I need to worry about, cancer? Or is this just like a regular thing? And so a lot of it is your assessment. You have to look at x-rays. Sometimes the x-rays haven't been read and you have to either call to have them read, or you trust yourself. Most of the time, most orthopedic surgeons are going to read their own films because we are used to looking at it and we know what we're specifically looking for because of the history, right? So the average, if you hung out with me and you did the virtual shadowing, can be anywhere from an 8 to 10, 14-hour day. So if I'm on call, like here I'm on call, the Indian Health Services, I'm on call 7 days. So anything that comes in at 2 a.m. and needs to go to surgery, I'm the person that does that. That's not the norm. Most places you may be on call every 3rd or 4th day. And that's when you come in and you get other cases that may or may not be in your field as well. So you may defer it to someone else. Those days may be clinic. I go to clinic 8 o'clock in the morning, I may get out at 5, and you're still doing notes till, maybe 6, 7 o'clock sometimes. So you have to document so you can get paid, right? The other things will be, like I said, consults that you have to go see patients that are in the hospital that have something wrong or need to be seen to see if they need surgery. So your day can be long or it can be somewhat short. And those are the days that you definitely enjoy, trust me. All right. So the other things that I do as an orthopedic surgeon that has been around for a little bit, I am, a speaker. I speak for multiple organizations. I have a book called The Rules of Medicine that I'll share with you guys as well. This is me speaking at Howard University. I've spoken at Spelman, UTMB, Galveston, Baylor, UT, so multitude, Texas Tech, multiple places that I go back and I speak. I recently spoke at the Academy of Orthopedic Surgeons that was in Chicago, and that was basically on diversity, equity, inclusion. Had nothing to do with orthopedics itself, but it's an issue, major issue in orthopedics and trying to diversify who we are and what we're doing. I sit on several boards, including the Institute of Spirituality and Health. It is a large nonprofit organization here in Houston in the medical center that deals with our spirituality side, from who we are and our essence and what we're going to do, and our long-term things that make us better as humans. And it's a board that I love being on because it's so diverse in the people you work with. I am also the vice president of Black Women Orthopedic Surgeons. Again, we started in 2020, realizing there's not many of us, and trying to establish some camaraderie because we needed the support to each other, to help each other. And so now we're into mentoring the next generation of Black women orthopedic surgeons that are coming in as residents. And then, we support each other from text to WhatsApp chat to meeting up every now and then and really trying to be there for each other. We have a group thread and just like, who is in California or who's in Chicago, or can you refer me to somebody there or whatever. I had a recent patient that was from Mexico, New Mexico, but was traveling to California, and one of the docs there was able to transfer the patient back to home because we knew each other and, was able to refer a patient out or whatever, so those kind of things become networking capacities that you want to be part of organization-wise. And then I have an upcoming podcast that we'll be doing called Ella, which is her in Spanish, that is about Black and Brown women who are disruptors in their field. So looking forward to that. You guys can hear more about that later on. And then, me being a locums doctor, meaning, I travel only 7 to 10 days out of the month. I've done as long as 6-month stints, when my kids were smaller. But, now I'm a mom of a 16-year-old that's going to college next year, a 14-year-old that's going to be in high school this year, and my son that's going to be in 5th grade next year. So their schedules are just as busy, if not busier than mine. So doing what I do, I'm able to be mom as well. And then also my husband, hold on, Tim, mom's on a call, being mom, right? And then the other thing is my husband's pastor of a fairly large church here in North Houston. We have over 5,000 members, so I've helped with the health ministry. This is us, actually, we built a clinic in Haiti that helps a population in a year of over 100,000 people that don't have basic necessities of vaccinations to treatments for sexually transmitted diseases to bumps and bruises. This is a basic clinic that has its own well water and that kind of thing, And then my passion is Sloan STEM plus arts. It's a summer camp that I do through our church that we normally try to do Black and Brown population because minorities are less likely to go into STEM, but STEM careers, including medicine, have the propensity to have six-figure salaries, right? And so therefore it's creating a sustainability for those communities that normally would not have that option. So these are the things I do, my passions. And then lastly, I have the book that I wrote. Let's see if it'll advance. The book is, what did I do with my book? The Rules of Medicine, there it is. The Rules of Medicine was once I finished my orthopedic surgery training and had been out in practice for a while, I realized there was a lot of things that no one had ever said to me. There was things I had heard or we jokingly talk about being really jovial about, see one, do one, teach one, that kind of thing. But you heard it, but you didn't really get the idea or understand the importance of it. And so the book is a short read. I encourage you to get it if you're going into medicine. It tells you basic things that people may or may not tell you, but it's going to help you be successful. And so the last rule in the book is called Rule 34, pay it forward. And it's about even once you finish and you're busy and you have your own life and whatever else, it's about doing things like this, the virtual shadowing of coming back and providing and helping the next person get to where you are, because it wasn't easy and it took a lot of people to make me who I am today, as well as whoever you're going to be becoming in the next few years. So I hope you guys definitely want to have an interest in orthopedic surgery. It's a great field. I love what I do, but there's definitely options to create the lifestyle you want. So any questions?
Well, definitely, first of all, thank you so much for that great presentation. We love to see the clinical practice and we love to see kind of the extracurriculars outside of that. It's unique to have that as a physician. Usually people are already busy, with practice, but if you're able to add on to that, that's extremely special. And seeing that actually happen, in action,
Yeah.
is greatly admirable. So we do have a few questions that rolled into the chat, and I'll just read out them and feel free to answer as you'd like. So the first question is about if you need any physical strength for orthopedic surgery.
Great question. That is a great question. A lot of people believe that you do have to, you need to work out. You need to have some physical strength. Do you have to be muscle man? By no means. Do you have to work out every day or whatever? No, but it's one of those things. It definitely helps with certain things. I also believe that technique, how you do it, how you maneuver it, as well as if it's a procedure or whatever else, it may be about the sedation. So anesthesia becomes your best friend to put a patient to sleep to be able to reduce the bone. So you're not fighting the muscles and the patient, in pain or whatever else. So yes, some physical activity. You do not have to be the Hulk to do this. I mean, some of the smaller female orthopods, I kid you not, are dainty, if you will, but have a powerful skills and techniques to get things done. So yes and no, yes and no.
All right. So our next question is about burnout. So you mentioned the length of training being 14 years, and regardless, even if you're taking like the minimum for residency, I think it would be at least 11.
Yep.
So I mean, regardless, it's at least a decade. With that said, at any point of your medical journey, did you feel any burnout? How did you address that?
My burnout was probably because my residency was so hard. The worst night of my life, and I will share it with you, was cardiothoracic. So I was of the generation where we didn't have the 80-hour work week yet. I think the year I was leaving, they were implementing the 80-hour work week, and there was still a gray zone because people weren't really adhering to it, if you will. So there's 168 hours in a week. And there was one week I worked 142 hours, and I was on cardiothoracic surgery. My general surgery year, you have to rotate through different, specialties. And I was supposed to be leaving post call. And the guy that was coming on was doing a procedure on a patient, like a chest tube or a central line or something like that. So he couldn't come back to the operating room, and the patient they had just operated on all day had to go back to surgery. And so I was it. You didn't leave the hospital if there was care to be done, because that's what a doctor would do, right? That's what a surgeon would do. So after being at the hospital for like 36 hours, then I was in surgery for like another 8 hours. And I was so tired, I couldn't even drive home. I had to sleep at the hospital, and I just slept at the hospital because I had just been on call. But it was one of those days that I realized this is not necessarily what I want long-term for my life. It got better, definitely got better, but the burnout happens when the monotony of what you're doing becomes too much. As well as not having any outside self support or the support system. I call it "Get a Life" in my book, and getting a life. It was like my husband wasn't in medicine, so he gave me a different perspective on things in life. I had a great church group, and I was part of other organizations that when I did have time off, I was either sleeping or I was involved with those organizations. So burnout happens when you don't have associations with other things that are outside of medicine, I do believe. And then it's also about boundaries, because even in medicine, sometimes the residents, we're going out for a drink, or, come over and hang out at Bob's house or whatever else. And it was like, I've already spent 24 hours with you guys. I really just need, my own space, my own time. And so sometimes it's about creating boundaries, about that, so you don't get burnt out. And then I was definitely about therapy. Like, everything we were going through was traumatic, as well as some of the things I had to endure as being a only female at the time that I was in residency, and being the first Black female as well. There was a lot of psychological trauma. And so you have to have a great therapist as well to deal with yourself, and understand that's okay. Understand that you need that sometimes. Great question.
Yeah, actually, the rest of our questions really align with much of what you said. Kind of funny enough, it's almost like you're reading off of them. So the next one is actually about the same thing, about your familial and just general relationships with others, given the long time of education balancing that with work. I guess it's really the essence of what people ask about when we talk about work-life balance. Do you have any thoughts you want to add on to that?
Yeah, I definitely, again, in my book, The Rules of Medicine, is I Get a Life. It's called Get a Life. And so if you don't already have a great support system, and that support system may or may not be parents, it may or may not be brothers and sisters, cousins, whatever. It may come from people that are in that arena that you're in. And so even in medical school, your family became some of the other medical students, and that was okay as well. But you had a life. Like, we would sometimes travel together, and or we would go eat, and it was like no medicine is talked about, or whatever else. And then the journey changes as you go through medical school and residency, and even into practice. You have different relationships, and understanding not all relationships are going to carry over, and understanding that you are also growing as a person, as a doctor too, in the relationships that you want. I have some friends that have no relationships in the hospital other than their business office person and their head nurse or whatever else, because for them, their family and their life, they keep it totally separate, and I think that's admirable, because it protects them as well and gives them a sense of when they go home, they are mom or their dad, and it's not doctor, it's not surgeon. And so the concept and the perception of you being this superhuman, super person, whatever else, they're able to let their hair down, if you will, and have a normal life. I think travel is important. You have to get out and take the vacation time. And even if you're not going to, go to the Maldives, take the time and just turn off the phone, turn off the computer, no emails or whatever else, and just have some downtime that's just for you, that is understandable. And then I think also for me, and it was hard initially, hire someone. I think women specifically were taught that we have to do everything. And I was one of those women that was like, oh, I've got to do the laundry. I've got to get the dinner. I've got to clean the house, and, and be the spouse, super woman, super lover, or whatever, stuff. And it wears on you, because you're already doing amazing, massive occupation, and so therefore having to balance that out, I figured out, yeah, let me hire someone to clean. Let me hire someone to cook. Let me hire someone to take care of the kids. Yeah, it's okay to get a babysitter. Oh, it's okay to have a nanny. It was okay during COVID, we learned how to not have so many meetings and do Zoom things or whatever else. So it wasn't always a necessity to have to go to another meeting in the evening and miss out on my kids, whatever, right? So you learn and you put boundaries up, but hire people. You can Uber Eats, DoorDash, whatever else now. It's not about you being Chef Boyardee in the kitchen and trying to do it all. Learn to balance and find help, because you'll need it.
Yeah. Sometimes we think we're the only people who can do everything, but leveraging other people is just much easier.
Mm-hmm.
The next few questions go along with much of what you were talking about earlier. In fact, we just had one person just comment, just thanking you for how open you are and honest you are with your experiences. The next question we have is about the biggest challenge you face in your career.
Ooh, I think that is okay. So one will say balance, work-life balance, the not trying to do it all, be the superwoman. The other one would be definitely the diversity, equity, inclusion. Again, as I was in Baylor, I was the first Black female. I was the fourth female in the program. And the woman that was before me, we're still great friends, Jennifer Weiss. She was leaving as I was coming in. So we didn't really overlap, and we didn't see each other. And then the woman that came in after me, Selena Poon, I was leaving and she was coming in. So we didn't overlap. So at all times in each one of our careers and as residents, we were the only female. And then I was the only Black female. And so in the South, there's still some ideas and beliefs and some implicit bias, as well as some unconscious bias, that lended to definitely the sexism and the racism that I'll be very open and honest about, that I had to deal with, that other residents didn't have to deal with. So it made it very hard sometimes to go to work. It made it very difficult to always have to prove yourself. But in ways also it did make me a stronger person and a better surgeon. But I will say it was probably the most challenging, even to the point when I wrote my book, The Rules of Medicine. I was almost apprehensive to discuss some of those things because it was like, is it okay to talk about this? And it's like, you better believe it. These are things that happen. These are things that are real. And it's not like I'm telling on anybody, but it's a massive problem across healthcare in itself. And so that is the big push for diversity, equity, inclusion right now. But what I want to remind people is like, it's like, oh, you're going to invite me to the dance? Like, oh, that's great. I get to dance. Oh, but can I decide what I'm going to wear to the dance and how my hair is going to look at the dance? Or are you going to judge me for that? Or can I bring other people to the dance now that I'm here? Can other people that look like me also come to the dance? And so that is what diversity, equity, inclusion is about. It's not, oh yeah, we're just going to let a person in as a woman or as a Black or as Hispanic and Latino, whatever. It's not about that. It's about being part of the planning process for the dance. It's about being, the president of the committee for the dance. It's about opening the doors for everyone to come to the dance. And so that's one of the major pushes right now for orthopedic surgery, is in diversifying and understanding the intersectionality of who we are in medicine.
Yeah, funny enough, we actually had a whole session dedicated to diversity in medicine, and she was a program director, I believe, or at least a faculty member.
Sorry.
No worries. So she was a faculty member at the residency program over there, and she mentioned that they've studied how diversity will improve the performance of teams. It's not just, having it on board. It actually is shown to improve the performance of how people carry out their work life.
Right.
So,
and on the corporate side, there's an article, I wanted to say it came out in 2017-18, that looked at corporate organizations that had a more diverse workforce. And those organizations had like earning capacity and or financially more beneficial, like to the 10 to 15% range for businesses, which is major, than other organizations that did not diversify. So now corporate America has shown how it benefits organizations to be more diverse, and medicine is always sort of trailing behind. So I'm hoping and believing that it's going to eventually become more diverse, but we've got a long way to go. And again, with having 14 years to make an orthopedic surgeon, it's not like it's going to happen overnight.
Yeah, agreed. Our next question is about the stigma around mental health. So at the time that you were in training, at the time that things were pretty hectic in terms of your schedule and residency, was there any stigma against seeking help for mental health?
Oh, you better believe it. I was from 99 to 2006 in my residency training and medical school, 95 to 99. And so at that time, mental health was just now really being broached, and probably not to the latter half of that, starting to be accepted as okay to get help or get treatment or talk about it. And realistically, and I'll be honest, in surgery, it definitely was not. It was not that. It was almost like if you had to, you were almost not condemned, but looked down upon as a weak link, if you will, so therefore, for women, it was like you had to be hardcore. You had to be on top of your game. You couldn't let them see you sweat. You couldn't let them see you cry, and so that type of mental gymnastics on a regular person, let alone someone that may have had some other issues and there are some background traumas or whatever else, wasn't something that was really dealt with when I was in residency. We didn't have that outlet. No one was telling you get some help or seek. And I remember specifically, there was an anesthesiology resident that committed suicide. We were in the operating room. We were waiting for that person to come in to help put the patient to sleep. And everybody was looking for that person and paging. And they found that person in the stairwell with, unfortunately. So it was traumatic for all of us, because that was the wake up call of like, okay, we're not okay. And you know what? It's okay not to be okay, and to get the help you need. And when I say this, and hear me when I say this, in the end, when it's all said and done, the people that you're working with day in, day out, that you may go through training with or whatever else, won't be the people that will be at your bedside when you're sick. They're not going to be the people at your graveside crying because you're gone. They're not going to necessarily always be the people that are going to give you the awards and the accolades and the pat on the back because you've done well. So put that into perspective when you're training and doing something, and realize what really matters is your support system, is your friends, is your families, are your associations, true meaningful associations.
Absolutely. I think a lot of people miss that, thinking it's so much of their world when later on in life it won't be the case.
Not at all. Yeah.
And to kind of branch off into your extracurricular works outside of clinical practice, one of them being virtual
Doc.
orthodoc, sorry about that.
Yeah, that's
So
okay.
since it is about, kind of the advances in technology, the new sphere of telemedicine, how have you kind of have you found this as the best time to do it, or how have you decided that I wanted to go on and initiate this? What was your inspiration behind it?
So I started virtual telemedicine or telemedicine, that was 2015, I believe. 2015 is when I saw the writing on the wall. More so, I was investing. It wasn't that I was really trying to push it in my practice. It was I saw this as a something that was coming down the pike that we're going to have to get behind, because it's basically creating a less cost or overhead for insurance companies, hospitals, and that kind of stuff. And so virtual medicine, telemedicine, I remember saying this in 2016, was this is going to become the triage, if you will, for all of healthcare. And here enters global pandemic in 2020. And that's exactly what happened. Was you couldn't get patients to the hospital, or patients could not be seen in the hospital for, protective reasons for them as well as for us. And so therefore telemedicine skyrocketed, and out of nowhere, all of these new companies pop up, and the credentialing and yada, yada, yada. So I was ahead of the game as far as the investing side of it. It hasn't really taken off within orthopedics. It has on certain things. So like a patient post-op, you can do a telemedicine visit and bill for it. If it's a patient that is going through physical therapy, you can actually do the telemedicine with the patient and the physical therapist and bill for it. Basic things like, hey doc, my shoulder doesn't move, and then you're trying to do a physical assessment. So can you keep your hand up? Can you put your thumb down? Does it turn when you turn it down? Does that hurt in your shoulder? Does it hurt in the front versus the back? So there's some limitations, but at the same time, there's a lot of benefits to telemedicine. It's going to continue growing. And so in that sense, I think I was right on time with the telemedicine, virtual telemedicine. It is changing. It is growing. There's still a lot of room to grow. Other thing you have to remember is medicine is always behind almost 10 years with any type of technology, if you will, partly because most companies can't afford to bring in that type of technology, short pace, the turnover or the lifespan of that technology is going to change in the next 1 to 2 years. And so therefore they're reinvesting something else. Some of them don't have the research that's a level 1 type of research that has had a double blind, with 20,000 patients and all this other stuff. So medicine lags when it comes to technology, and they're trying to catch up. Things like AR, augmented reality, virtual reality, and how we put that into surgery and clinic and other things now. That's going to come down the pike as well. It's there. I was just at a conference, and that was one of the major things, VR. They had the Oculus, and my son, he's in there playing right now. So it's how do we get that part into our current healthcare and world in real time that is going to be beneficial without being forced to do it by a global pandemic. And that is the sticking point for medicine. So it's still growing. There's still room for a lot more growth, definitely. But anything technology-based is great for investment. Anything that's going to decrease overhead costs for hospitals and insurance companies, you better believe it. Yeah, it's coming. It's definitely coming.
So we have another question in the chat about when you were at that point in medical school deciding on what residency you're going to pursue, did you have any other considerations aside from ortho?
General surgery, and I loved urology. Actually, urology had really cool procedures that I liked. It was also you sort of get in, fix it, and you're done, And most of the surgery weren't too long unless like tumor or whatever else. So that was one of the other things I did like, urology. Again, cardiothoracic was interesting to me, but definitely not my forte. I love heart surgery, love all that other stuff, but patients were really, really sick or more deaths or whatever else. So that just really wasn't for me. And then realistically, the other thing was I did like plastics, but I just didn't see myself long-term doing plastic surgery. So, yeah.
All right. Well, seems like you had surgery as definitely the main thing, but there were a
Yeah.
few specialties in there.
Mhm.
Going back to your training path, so you mentioned there's your first surgical year as an intern, and then from there residency for 4 years in ortho. But specifically with that first year, are there any unique challenges to
For
that first?
general surgery year or for ortho
Yeah,
year?
for your first year of general surgery as an intern?
I think, as a intern, I remember being on call and I was at the level 1 trauma and we were carrying pagers still at that point, and they weren't little pagers. They were actually the big block pagers. And so I remember the first night I was on call and I kept hearing, Dr. Sloan, please call the operator. Dr. Sloan, call the operator. And the nurse that was sitting next to me, she says, isn't that you? And I'm like, they're calling me? Because it was about the responsibility. You went from being a medical student with no power, no control, no decision capacity, making it there like overnight, all of a sudden, everyone was depending on you to make all the decisions, make the calls and get them right, So that was a moment for me that I realized I'm in and you're responsible, and then the other one would be the first patient that was a very traumatic death, and learning to deal with. We're taught in residency, in medical school and in residency, about the living and how to keep people alive and how to deal with the disease process that we can make it better or whatever else. But we didn't really deal with the capacity of death and dying. And so I remember being at the VA hospital in general surgery in my first year, and the guy was really, really sick, and he'd had a surgery and got septic, which is the infection throughout the body. And the ICU nurse calls me and she says, "Come quickly, but slow code." And I was like, slow code? I hadn't really heard that one. Slow code means basically we're going to code them, but they've pretty much already dying, and we're not doing a service to them to keep them alive at this point. And the family wasn't around to sign a do not resuscitate. So I get there and I'm doing all this work and I'm putting in lines and trying to get the medicines and I'm doing all this other stuff. And she walks over to me and she says, "It's okay to let them go." And it was the first time I realized death was part of the process of life. And in medicine, we try to stay away from it because that makes us look bad, right? Because we did something wrong if they die, right? But it is a natural part of life, and understanding it's okay to sometimes let them go. So that was a very pivotal point in my career in surgery, as being a surgeon.
Yeah, death is just something that's going to eventually happen at one point or another, but medicine is basically the force behind that delay.
We do everything, yeah, to keep them alive, everything, yeah.
So I guess to end off our session with maybe the last one or two questions, I wanted to jump into networking. So being in a leadership role like yourself, you're a part of many associations, organizations. You just mentioned it there when you were talking about patients from Mexico, referring them to California, different states like that. So, this is nationwide networking. Do you have any tips for the undergrads outside, listening to us for whether it be now or later on in their career in medical school, residency, and so on, where they can capitalize on the opportunities that present themselves in terms of networking?
Oh my gosh. So I think I was on a TikTok and I said, what is the one thing that you were taught that was a complete lie? And I said on the TikTok was that if you study hard and you do everything correct, you can, have anything you want and you can go very far. As it is the biggest lie we were ever taught. We were not taught early enough what the capacity to network does for you. Networking will allow you to be in some places and enter some doors and rooms that you would have never had the opportunity, regardless of your credentials. So I'll say this: never burn a bridge, because you never know when you're going to have to come back across that bridge. And so even if you find the hardest person to deal with in medicine, whoever that is, I don't care if it's a nurse, a doctor, or a fellow colleague, you remember you're here to learn a trade, to be able to do an occupation. You're not here to be everyone's best friend. Okay. So that's one of the things. As you are meeting people, it's great to create that relationship, if that's a direct message, if that's an inbox, if that's an email, so you can sort of stay in front of that person, thinking later on that this is someone that could possibly help you, as well as, be sincere. People can read you. People will know your motives. People will know if you're genuine, and those are the people that will say, "Oh yeah, they were a nice person, and I actually liked them. There's something about them I liked, or whatever else." And those are the people that will come back to help you and or open some doors, or will be the person that will refer you to somebody else and say, I don't know the person, but call this person. And so just being sincere, genuine, but also very open and honest, most people will take to that because it's not always the norm in medicine, if you will. So definitely the networking is huge, and you will never get away from it. It's always going to be there. So remember that. And I said, sometimes your biggest commercials or your advertisement are going to be people that you work with, and so don't piss any nurses off or be mean to other doctors or whatever else, because those are the people who are going to go home and say, that doc, I would never send a patient to them. And then you know what? They're going to tell 10 people, and then they're going to tell 10 people, and and now you've been pretty much shunned. And that reputation is really, really hard to change. Very, very hard to change in medicine.
Yeah, absolutely. So I guess we can just end off on one question. And with orthopedic surgery being a pretty competitive specialty, and medical school in general is still competitive in nature, where did you find your success amidst the thousands of applicants? What do you think brought you to where you are now?
Definitely the sincerity and the realness of who I am. I also had some other life experiences that I think made me a little bit different than most people, that I was not necessarily the norm person that just went straight through medical school. I mean, undergrad and then medical school and residency, whatever else. I sort of had some, stops here or there. I had some life experiences that really benefited me and helped me grow up. I became an entrepreneur. I didn't get accepted the first year out of medical school. I graduated from tech and got waitlisted at Chicago at Rush. Was waiting to hear from them. And, my husband and I had met, we knew each other growing up and we're home that summer. I call myself being mad at God, but I also learned very quickly, if you want to hear God laugh, make a plan, because we are taught that, you got to go to college and you've got to go to right into medical school and you've got to then get into a residency program. Then when you finish, you've got to start a career, and then you got to have, have a significant other and start this life, and you got to save to retire. And we have such strict ideas of what our life is supposed to be. It doesn't really leave any room for error or failure. And those are the moments that create your character. It creates your tenacity. It creates your wherewithal that will keep you going, as well as show you who you really are and the passions that you have. And so when I didn't get into medical school, starting my own business, it taught me entrepreneurship that led me to have a nonprofit later on, that I've helped hundreds of women now start their own businesses, which will probably have greater impact than the number of patients I've done a shoulder replacement on. So in perspective, what is your impact? What is your legacy? What are you going to leave long-term? And it can't be just behind a desk, in the operating room or whatever else. It has to be bigger than you.
Well, I think that's a perfect point to end off today's session at. That's going to wrap up today's session, everyone. Thank you so much, Dr. Sloan, for joining in, first of all, and to our audience. Just a few last reminders. We have a quiz that's now released. It's posted in the YouTube chat box, so you can access it from there. Also, if you go onto our site under the virtual shadowing page heading, under there's our quiz. All you go to is just scroll down, and then you'll see past shadowing speakers. Above that is a box titled quiz, with that doctor's name, Dr. Sloan in this case, or whoever might be in the future. Click onto that, and then you'll see the quiz link. You must attain at least 60% or higher on that quiz to pass it. And if you do, you'll be sent a certificate with the email or to the email, I should say, that you listed on that quiz. If you don't find the certificate, please look in your spam folder, but if not, feel free to email us and we can help out. This quiz will be due at 11:59 p.m. Central Standard Time this upcoming Wednesday, April 27th. And for our next shadowing session, you can join us with Dr. Serino over infectious diseases on Thursday, April 28th at 7 p.m. Central. For those who are new, we operate on a weekly schedule on Thursdays at 7 p.m. Central. So you can really just expect to see us then. We do have semester breaks and we're approaching our summer break, but we'll let you know ahead of time when that does come. Again, thank you so much, Doctor. Do you want to give out your Instagram for anyone who would be interested?
Yeah, I'm Sonia Sloan, Sonya, Sloan, Sloan, MD, on Instagram, Twitter, Facebook, TikTok, all of them. You can find me there. And then my book is called The Rules of Medicine. It's also on my website at sonyasloanmd.com.
All right, perfect. Well, thank you so much again to
Thank
you,
you for
and
having
the
me.
audience. We really appreciate it. It's been such an informative and insightful